Good morning, everyone. Thank you so much for joining us for this Africa Calls Cytology session. We're very excited to have Dr. Oscar Lin, who Dr. Leslie Lomo will introduce in just a moment. Before we get started, I wanted to remind everyone that on December 20th, we have an Africa Calls Cytology Echo. And for that, we need some volunteers to present cytology cases. If you're interested, please email me directly and let me know if you would like to present. We need 2 people for that December 20th session. And with that, I will turn it over to Dr. Lomo to introduce Dr. Lin.
Greetings, participants, and welcome to today's session of Africa Calls. I'm Dr. Leslie Lomo here at the University of Utah in Salt Lake City to moderate today's session with Dr. Ali Lowe from Stanford. It's my very great pleasure to introduce today's speaker, Dr. Oscar Lin. Dr. Lin is the Cytology Service Chief in the Department of Pathology at Memorial Sloan Kettering Cancer Center in New York City, New York. Dr. Lin received his MD and PhD degrees from the University of Sao Paulo in Brazil and completed his residency training in anatomic and clinical pathology training at the New York University Medical Center. He then completed fellowships in oncologic pathology and cytopathology at MSK. Dr. Lin joined the staff there at Memorial Sloan Kettering in 1999 and has held a number of leadership positions, including the medical director of the School of Cytotechnology, head of the Fine Needle Aspiration Clinic, and chair of the Department of Pathology QA Committee. He currently leads a team of 14 cytopathologists and is also a member of their hematopathology service. Dr. Lin's many publications reflect his expertise in cytopathology and his research interests, which include digital pathology and telecytology, precision medicine, and lymphoproliferative disorders. He also serves on the editorial board of the Journal of American Society of Cytopathology and Diagnostic Cytopathology, and is a current member of the executive board of the American Society of Cytopathology, or ASC. For the ASC, he most recently served on the Telecytology Validation Task Force, presenting the results of that group's important work at the latest ASC meeting 2 weeks ago. A final highlight among his many accomplishments includes his authorship of several chapters of the upcoming WHO reporting system for lymph node, spleen, and thymus cytopathology, and therefore we are so excited to have him speak today on this topic. Without further ado, I will turn it over to Dr. Lin.
Good morning. First of all, I would like to thank ASC and ASCP, particularly Dr. Loma and Dr. Lowe for inviting me to present today. It's a great pleasure to present the topic of the WHO reporting system for cytopathology of lymph node. So the goal today is to discuss the morphology approach to the most common lymphoid lesions in cytology. And then we are also going to discuss the use of ancillary studies when we encounter a specimen that contains many lymphoid cells. And I think it's important to understand these 2 topics before we discuss the proposed WHO reporting system for lymph node FNA, because the reporting system will require the association with the ancillary studies in order to report the specimen. We would like to first understand what's the role of cytology when we're evaluating lesions containing many lymphoid cells. Cytology can be used for screening and to distinguish reactive conditions from lymphoproliferative disorders such as lymphoma, or sometimes to rule out metastasis involving a lymph node. If a lymphoma is diagnosed, in many situations, the cytology can provide a primary diagnosis, although there are certain cases in which there are some limitations. Cytology can also be used for staging. For instance, a patient who has a diagnosis of Hodgkin lymphoma in a neck lymph node and also has lymphadenopathy elsewhere, and the clinician wants to know if the other lymph nodes are also involved by lymphoma or not. And another role that we have seen cytology being used is in the evaluation for potential transformation. This is particularly useful when the patients have a long history of low-grade lymphoma and they are being followed clinically and suddenly presents with a large lymph node, with an increased SUV, and the clinician wants to know if they might be dealing with transformation that might require a change in treatment. And I think that when we're dealing with fine needle aspiration of lymph nodes, it's very important to perform a rapid on-site evaluation. And I'll touch on this importance later on when we discuss the ancillary studies. But when we have a specimen for rapid on-site evaluation, the first thing that we have to look for, or the first thing we have to evaluate, is the cell size. So in this case, what are we dealing here? Basically, we're dealing with a predominant population of small lymphocytes, which are the predominant population is small lymphocytes with very condensed chromatin pattern, although at mix we see a few larger cells with more abundant cytoplasm and vesicular chromatin pattern and prominent nucleolus. And how do I determine if a lymphocyte is small or large in size? The small lymphocytes are characterized by being about 1 to 2 times the size of a red blood cell. So, and we know that in average, a red blood cell measures about 4 microns. So anything up to 8 microns will be considered a small lymphocyte. And something that's larger than 10 microns would be considered intermediate, and anything larger than 16 microns would be a large lymphocyte. Another way to tell them apart is through the presence or absence of a prominent nucleoli. The small lymphocytes do not have prominent nucleoli, while the large lymphocytes frequently have distinct prominent nucleoli, and the chromatin pattern, as I mentioned before, is also a good clue to distinguish between a small and large lymphocyte. Sometimes, depending on the preparation, the distinction can be challenging. And when we look at lymphoid-rich lesions, we have to, as I mentioned, we have to pay attention to the cell size. And I'd like to we use 3 different patterns to distinguish the different categories. One pattern is a pattern composed predominantly of small lymphocytes. Another one is when most of the cells are intermediate to large. And in this group, I can also include the pleomorphic and blastic cell pattern. There's another pattern where we see single large atypical cells in the background containing many small lymphocytes. And this third pattern is a little more challenging, and we are going to go through this pattern later on. Let's start with a lymphoid specimen composed predominantly of small lymphocytes. We can see in this Giemsa-stained slide a predominant population of small lymphocytes with a few scattered large cells admixed. These large cells are quite round. They might have a nucleoli, but they don't show marked atypia. When we encounter a specimen such as we just saw, the main differential diagnoses include a reactive lymph node, a low-grade B-cell lymphoma, and in the Western world, less likely there is a possibility of T-cell lymphomas. This is a picture of an alcohol-fixed Papa Nicolau stain smear of a reactive lymph node. Again, we see a predominant population of small lymphocytes, very small. It's very difficult to distinguish with small lymphocytes. We see a few larger lymphocytes with prominent nucleoli. As you can see in the fixed smears, sometimes it can be more difficult to distinguish the small or intermediate cells. And we also see the presence of tingible body macrophages, which are these cells with more abundant cytoplasm and some apoptotic cells in the cytoplasm. To distinguish a reactive lymph node from a low-grade lymphoma, it can be very challenging. We rely on clinical findings. So if a patient is young and the radiological findings are compatible with a reactive lymph node, then we can suggest that's a reactive lymph node. However, the only way to be absolutely sure that we're dealing with a reactive lymph node is doing flow cytometry studies. And here on the left, you see a classic appearance of flow cytometry studies from a reactive lymph node. On the top left, you see the gates looking for kappa and lambda expression. In this tube here, we see that the B cells expressing kappa are almost in the same number as the lambda expressing B cells, meaning that there is no clonality. There is no abnormal expression of CD5 cells. So here we don't see a distinct population of CD20 or CD5 positive cells, and there is no clonality here either. We also do not see a clonal population of CD20 and CD10 B cells. So in view of these flow cytometry studies, we can confidently say that we do not have a clonal B cell population, and it's unlikely that we're dealing with a lymphoma. On the other hand, if we see a clonal B cell population, as it is a flow cytometry example, where in this B cell tube, most of the cells are expressing kappa, therefore we have a clonal kappa expressing B cell population present, we are dealing with a low-grade B cell lymphoma. And the differential diagnosis when we see a clonal B cell population includes all the low-grade B cell lymphomas, including small lymphocytic lymphoma, follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, and lymphoplasmacytic lymphoma. And to distinguish each of these low-grade lymphomas, we can rely on some morphological clues and also on the flow cytometry studies. For instance, in this case of small lymphocytic lymphoma, we see a monotonous population of small lymphocytes. The cells are not much larger than the red blood cells, and these are H&E stained alcohol-fixed smear. Notice that in this alcohol-fixed smear, we can see the chromatin pattern. And in small lymphocytic lymphoma, the chromatin pattern has this distinct pattern. The chromatin is clumped, and it looks like a soccer ball. So we have round cells with this clumped chromatin, so it's a perfect soccer ball. Would I be comfortable making a diagnosis based on morphology only? Probably not. I would like to have confirmation with markers. And I think, again, flow cytometry is the best marker to identify and confirm the diagnosis of small lymphocytic lymphoma. In this B cell tube, where all the cells are B cells, we see that the majority of the cells express kappa. So we are dealing with a clonal B cell population. Most of the cells tagged in blue are expressing CD5 and CD20, as well as CD19. The cells also express CD23 and CD200. Additionally, the cells were expressing ROR1. So the combination of expression of CD20, CD5, CD23, CD200, and ROR1 are diagnostic of small lymphocytic lymphoma. Based on this immunophenotype and the morphology, I can tell the clinician that the patient has small lymphocytic lymphoma, and if the patient has only one lymph node that's enlarged and has no other disease, the patient can be followed clinically and no additional biopsy is required. Other types of low-grade lymphomas include mantle cell lymphoma. And for mantle cell lymphoma, the cells are not as round as we see in the small lymphocytic lymphoma. The nuclear contours are much more irregular, and the chromatin pattern is not clumped as we see in small lymphocytic lymphoma. Here at mix are some follicular dendritic cells, so we should not confuse these cells with a mantle cell lymphoma, which are these cells in the background. Flow cytometry studies, again, are quite useful to detect a clonal B cell population. So in this B cell tube, once again, most of the cells are B cells are expressing kappa. In this gate here, where we see CD19 and CD5, we see a co-expression of CD19 and CD5, although it's a sort of a dimmer CD5 expression. There is no expression of CD23, so the cells of interest tagged in blue are to the left, meaning that we're not expressing CD23, and we are also not expressing CD200. Based on the flow cytometry studies, we can conclude that we're dealing with a CD5 positive B cell population. In order to confirm that we're dealing with a mantle cell lymphoma, we have to rely on the immunohistochemical studies or cytogenetic studies. Immunohistochemical studies will show the expression of cyclin D1, or cytogenetics will show the presence of translocation 1114. Cyclin D1 is sort of unique to mantle cell lymphoma. When we're dealing with low-grade low-grade lymphomas, we cannot rely only on the CD5 because there are other types of CD5 positive low-grade B-cell lymphomas. Therefore, in order to confirm the diagnosis of mantle cell lymphoma, we have to either do the immunohistochemistry or cytogenetics. Another very common low-grade lymphoma is follicular lymphoma. In follicular lymphoma, as we can see in this Papa Nicolau stain alcohol-thick smear, the cells are small. They are slightly larger than the red blood cells. They have very irregular nuclear contours, but many of the cells have cleaved nuclei, as we can see in the blue arrows. We can see some admixed cells, which are larger. They have more prominent nuclei. In this case, we have two. And the cells have a vesicular chromatin pattern. So the small cells correspond to what we call the centrocytes, and the large cells are the centroblasts. Flow cytometry, once again, it's quite helpful to detect a clonal B cell population. In this case, the cells of interest are tagged in blue, and they express kappa, CD10, and CD20, as we can see in these lower gates. One of the issues in cytology when we're dealing with follicular lymphoma is the grading. On the left, you see that most of the cells are small in size, so this is most consistent with a low-grade follicular lymphoma, or grade 1 to 2, according to the old WHO's or the international consensus classification. In the new WHO for lymphomas, there is no need for grading follicular lymphoma. They are all lumped together. But in the ICC, the International Consensus Classification, they still maintain the grading. On the right, you see a specimen of follicular lymphoma where the small cells are cleaved, but we see increased number of centroblasts, which are these cells with vesicular chromatin pattern. This case might be what used to be called follicular lymphoma grade 3. It's very hard to distinguish grade 3A from 3B, or even partial involvement by diffuse large B-cell lymphoma. So when there is increased number of these large cells, we have to include all the higher grade follicular lymphomas in the differential diagnosis. Another low-grade lymphoma we might encounter in cytology is marginal zone lymphoma, and this lymphoma that's more difficult to make a definite diagnosis in cytology because we do not have a unique phenotype that can help us. There are few new markers that are appearing in the market that might help to identify marginal zone lymphoma, but it's still in the early stages, and there are no larger studies confirming the utility of some of these markers. So most of the marginal zone lymphomas are CD5 and CD10 negative B-cell lymphomas. You can see here. In this case, most of the cells are expressing lambda. The cells of interest are labeled in red. There is no distinct CD10 or CD5 B-cell population. Some of the marginal lymphomas might have a plasmacytoid morphology, which are best seen in the Kim's stain slides. In these situations, we can report that the patient has a CD5 and CD10 positive B cell population, and the differential diagnosis includes marginal zone lymphoma, although we cannot exclude the lymphoplasmacytic lymphoma, and other markers are required to make that distinction. As you can see, when we are dealing with a population of small lymphocytes, it is very important to collect flow cytometry studies if available. I understand flow cytometry is not available in many countries, especially underserved countries, so we can rely on immunohistochemistry. But the problem when we use immunohistochemistry is that many of the markers that we use to identify abnormal B cells are actually T cell markers abnormally expressed in B cells. And if we have distinct or we have many T cells infiltrating the lymphoma, it might be difficult to identify co-expression of the T cell markers in a B cell population. And for that reason, I really recommend flow cytometry studies, because with flow cytometry studies, it's possible to evaluate multiple markers in a single cell. And with immunohistochemistry, it's a little more difficult. Cytogenetics are helpful, and molecular studies are also helpful, although these are less likely to be available widely. So flow cytometry is very good because it has a very high sensitivity. It's over 95% in cases of low-grade lymphomas, and can be helpful to make a definite diagnosis in certain situations, such as small lymphocytic lymphoma, or if the patient has a prior study and flow cytometry is helpful to confirm recurrence. Immunohistochemistry, as I mentioned, can be difficult to in case of low-grade lymphomas, except in case of mantle cell lymphoma, where we have expression of cyclin D1. Cytogenetics has a more limited role, again, can be used to classify mantle cell lymphoma. In certain cases of marginal zone lymphoma, depending on the site, they can show a distinct cytogenetic abnormalities. And in case of lymphoplasmacytic lymphoma, the presence of the MOID88 is diagnostic of lymphoplasmacytic lymphoma. Other cytogenetics or molecular studies can be helpful to evaluate for prognosis in these cases of low-grade lymphoma. And molecular studies can be helpful to determine clonality, although IgH rearrangement sensitivity is lower than flow cytometry. For molecular studies, the sensitivity is about 80 to 90%. And with the advent of the molecular studies, we can use molecular studies since some of the lymphomas have more common molecular alterations, such as molecular follicular lymphoma that very frequently has MLL2, EZA2, CABP, AP300, MF2B rearrangements. So if these rearrangements are seen in a low-grade lymphoma, we can suggest that we are dealing with follicular lymphoma. So this is for what I have discussed. It's for low-grade lymphomas. But when we have a specimen that's composed predominantly of large cells, which are these cells which are much larger than the red blood cells or even the small lymphocytes that might be present in the background, the differential diagnosis is quite different. The differential diagnosis includes a large B-cell lymphoma, but also includes non-hematopoietic entities such as carcinoma, melanoma, or even seminoma when we're dealing with a retroperitoneal lesion. So it's very important when dealing with a population of large cells to confirm that we're dealing with a hematopoietic lesion. And to do that, it's very important to collect material for immunohistochemical studies. And once it is confirmed that we're dealing with a lymphoid population, you can see in this picture that in the 2016, the WHO already classified all these lesions with a blastoid or with a large cell morphology as aggressive B-cell lymphomas. So they include lymphoblastic lymphomas, Burkitt lymphomas, diffuse large B-cell lymphomas, as well as some translocated large B-cell lymphomas. And the reason why I suggest immunohistochemistry is because with a large cell population, it's very easy to identify the atypical population. And with immunohistochemistry for CD20 or PAX5, we can confirm that these cells are B cells. If possible, I suggest doing 2 B cell markers, either CD20s or PAX5 or CD79A, to confirm the B cell lineage of these cells. Nowadays, just the diagnosis of diffuse large B-cell lymphoma is not enough for the clinicians because we need to determine the cell of origin. So we need that prognosis for diffuse large B-cell lymphoma with a germinal center cell phenotype is very different from the non-germinal center cell phenotype. The germinal center cell phenotype is characterized by expression of CD10 or BCL6 in the absence of MUM1. The diffuse large B-cell lymphomas with a germinal center cell phenotype have a 5-year prognosis of about 5 years, while with non-germinal center cell phenotype, they have a prognosis of 30% in 5 years. And it's also very important to identify what's so-called double hit diffuse large B-cell lymphomas. These are large B-cell lymphomas that have c-MYC and BCL2 mutations. As you can see in this graph on the left, you can see that this is the line in purple. This overall survival is much lower than in the patients with double hit lymphoma when compared to patients with diffuse large B-cell lymphoma, germinal center or non-germinal center cell phenotype. These double hit large B-cell lymphomas are commonly CD10 positive. And just to a preamble for future WHO classifications, that most likely in the next WHO classification, not the one that was published last year, but for the upcoming future WHO classification, most likely will migrate from a cell of origin classification to a molecular classification. But it's still in the works, and there's many more studies to come. You saw that I recommended the use of immunohistochemistry in case of large B-cell lymphoma. I would like to put emphasis on the immunohistochemistry because flow cytometry is not as sensitive in large cell lymphomas, probably because the cells do not survive processing, and there's a gating issue when dealing with large cells. Just to give an example, it is a case that was a false negative case that we reported. Initially, we thought there were very few B cells, or if the B cells present in this specimen did not have any clonality. The number of kappa expressing cells and lambda expressing cells was very low. The issue is that the person looking at this case did not pay attention to this gate, which was the CD19 gate and the CD20 gate. That showed that this light blue B cell population was expressed in CD19 and CD20 and also CD10. Therefore, in this case, this was wrongly diagnosed as non-clonal, but in reality, in this case, we were dealing with a large B-cell lymphoma. We also have to be careful with when we're dealing with a CD10 clonal B-cell population, because in this case, we are dealing with a clonal B-cell population expressing CD10, and with differential diagnosis, if we are not looking at the morphology, we might misdiagnosed as follicular lymphoma. But we have to remember that all these three different types of lymphomas can express CD10. On the left, you see a follicular lymphoma with the cleaved cells. In the middle, it's a case of Burkitt lymphoma. This is alcohol-thick smear. We see a homogeneous population of round lymphocytes with a little more open chromatin pattern and several nucleoli, and many apoptotic cells in the background. So this was a case of Burkitt lymphoma that also flow cytometry. That flow cytometry also will show the presence of CD10 expression. And on the right was a germinal center cell phenotype, diffuse large B-cell lymphoma that also expresses CD10. Just a few words about Burkitt lymphoma because it has a unique morphology with a very monotonous population of round lymphocytes, and they have a very basophilic cytoplasm. It's much more basophilic than the diffuse large B-cell lymphoma, and we present with vacuoles in the cytoplasm. So the combination of this morphology, monotonous population of round cells with coarse chromatin, basophilic cytoplasm, and vacuoles in the cytoplasm, as well as CD10 B-cell population with the cytogenetics showing a c-Myc translocation, can allow us to make a confident diagnosis of Burkitt lymphoma and no additional biopsies required. In reality, if you see this morphology, you can already suggest Burkitt lymphoma, and it's quite important in certain patients because these patients might present with bulky disease and might require treatment as soon as possible. I just want to touch base about some large B-cell lymphomas that have a unique phenotype, and they usually might represent pitfall. Most of these lymphomas are lymphomas that B cells, the cell of origin are B cells that are between immunoblast and plasma cells. So these lymphomas include primary fusion lymphomas and plasmablastic lymphomas. And this is a classic case of a plasmablastic lymphoma. The cells have a plasmablastic morphology with eccentric nuclei, prominent nucleoli, and the nuclei is eccentric. In a few cells, they can have an immunoblastic morphology. Cells are round with a centrally located nuclei and prominent nucleoli. They represent a pitfall because all the B-cell markers are usually negative. Even CD45 might be negative. These cells will frequently express CD138 and might be confused with plasma cell neoplasms. Most of these plasmablastic lymphomas are associated with EBV expression. And rarely plasma cell neoplasms are associated with EBV. The original description of plasmablastic lymphoma was in HIV positive patients and in a pediatric population. But since its original description in the late 1990s, there has been several descriptions in the adult population and non-HIV positives. So just keep in mind that if you see a population that looks plasmablastic or immunoblastic, and the CD20 or CD79A is negative, or even CD45 is negative, always add CD138 and EBV. And if necessary, we need to order molecular studies, because molecular studies will show the presence of IgH rearrangement. Clinical information is very important in these cases. And primary effusion lymphomas is another potential pitfall. They usually present in the body cavity fluids. The cells are very large. They look like the cells that we saw in the plasmablastic lymphoma. They usually do not present with solid masses. So these are diseases located primarily in the body cavity fluids, although there are rare reports in the that are present as solid masses, but it's much less common. These cells have a very similar phenotype to the plasmablastic lymphoma, except they also express CD30, and they're also associated with HHV8 viral infection. And we are not exclusive to a body cavity, to the pleural or the peritoneal cavity, but they can also present in the CSF. And this is another marker, another disease that can present a morphological pitfall. It's an ALK-positive large B-cell lymphoma. The cells are large, they have prominent nuclei, and the problem is that they frequently present as clusters, mimicking carcinoma. As we know, whenever we see clusters, we do not think of lymphomas. Usually, lymphomas present as single cells. So if the keratin markers are negative, it's always important to also include some hematopoietic markers such as CD45. Some of these ALK-positive large B-cell lymphomas might be CD20 negative, so it's always interesting to add ALK if nothing else is working. And the ALK expression pattern is different from the ALK-positive anaplastic large cell lymphomas. In ALK-positive large B-cell lymphomas, ALK is usually expressed as a cytoplasmic pattern with and they look granular, contrary to the anaplastic large cell lymphoma, where we also see nuclear staining. And the third pattern that I would like to discuss is the pattern where we see large atypical cells in the background of small lymphocytes. So these cells have very coarse chromatin and prominent nuclei, and they just comes up to your eye when you look at these smears, although sometimes you really have to screen very carefully for these cells. The most common disease that we present with these atypical cells is Hodgkin cells. Here on the top left, we see a classical Reed-Sternberg cell with binucleated nuclei, bilobated, and with prominent nuclei, as you can see here on the bottom, in an alcohol-fixed smear. In order to make a definite diagnosis of Hodgkin lymphoma based on cytology, it's very important to do immunohistochemistry, and the cells should be positive for CD15, CD30, and show a weak expression of TAX5. Personally, I would only make a diagnosis of a Hodgkin lymphoma if the patient is young, 20 or 30 years old, or around 56 years old, which are the peak incidence for Hodgkin lymphoma. And we also have a phenotype showing the expression of 15, CD30, and a weak PAX5. In the absence of a classic phenotype, I would actually say that suspicious and suggest a core biopsy or excisional biopsy, because there are pitfalls that we can encounter, such as case of post-transplant lymphoproliferative disorders. In this case, was a patient post-renal cell transplant. We might be dealing with a patient with primary mediastinal B-cell lymphoma, where we can see these Hodgkin-like cells, or even a T-cell lymphoma, where these atypical cells can be present. Flow cytometry can be useful in the diagnosis of classic Hodgkin lymphoma, but it's of not many institutions or organizations have the tubes for classic Hodgkin lymphoma. Even in the United States, most of the flow cytometry labs do not run a tube for classic Hodgkin lymphoma. We actually perform here at Memorial Sloan Kettering, and it has shown a very high sensitivity over 90%, with a very high specificity of over 99%, with a caveat that these specimens must be cellular and have more than 100,000 cells. And one thing that we found was that we call a T-cell marker, where we see an increased expression of CD45 and CD7 in case of Hodgkin lymphoma. And this gate is quite useful when the phenotype is not as clear. I also want to point out there are two entities that I find very difficult to make the diagnosis using cytology specimen, which is the nodular lymphocyte predominant Hodgkin lymphoma or the T-cell rich B-cell lymphoma, because we do not have a unique phenotype that can be detected by flow cytometry. Actually, flow cytometry will not detect these malignant cells because of the low number of cells. And this is just an example. I'll go briefly through the T-cell lymphoma because I would like to allow some time for discussion after I present the WHO system. So T-cell lymphomas are much less common, at least in the Western world. There are differences in the types of T-cell lymphoma depending on the geographic distribution. You can see that in Africa, the T-cell lymphoma NOS is much more common, followed by angioimmunoblast T-cell lymphoma and some case of hepatosplenic lymphoma. And this is a classical case of angioimmunoblast T-cell lymphoma. Can be confirmed with the use of flow cytometry studies, where we can see a clonal T-cell population. And the plasma cell lymphoma can also be detected by cytology. We see these wreath-like cells, which are very common, and it's associated with certain cytogenetic modification with the DUSP22. I'm going to skip this in the interest of time. And I would like to discuss the proposed WHO system, which is actually a modification of the Sydney system. And was devised mainly to address some difficulties that we had when we tried to report cytology specimens, especially FNA specimen. So this is a 24-year-old female with a FNA of the right cervical lymph node, has a population of small lymphocytes, some teachable body macrophages. So what should we call it? When we see a population of small lymphocytes and some large cells, what's the best approach? And if we see a large population of large cells, can we call it outright positive or not? So the WHO system was devised as one of the systems that have been proposed for different types of cytology specimens. First devised in Sydney in the IAC meeting that we had, and has transitioned last year to the International Agency Research in Cancer publication supported by the WHO. It's a 5-tier classification, including inadequate, benign, atypical, suspicious, or malignant. First of all, the inadequate category includes specimens that have no cells or very few cells, mostly blood specimens, or if the cells present are not representative of a lesion. For instance, a patient with a large cervical lymph node or enlarged node, the biopsy shows only benign salivary gland tissues. That means that the intended lesion, it was not present. The risk of malignancy is pretty high, ranging from 10 to over 60% in the literature. So there is an indication for repeat biopsy in these situations. The benign category should be used only when the clinical presentation and the ultrasound findings are consistent with a benign process, and flow cytometry, when available, is consistent with a reactive process. It includes case of acute inflammation and granulomatous inflammation. So it's a case of where the radiological findings helped. On the left, it's a benign lymph node. It's an elongated lymph node where we can see the hilum. In contrast, we have a malignant lymph node on the right. The cells are actually, the lymph node is round, and we cannot see the hilum. And granulomatous inflammation will be included in this category. So in this other case, we see a population of small lymphocytes with tingeable by the macrophages and no clonality with the flow cytometry studies. The risk of malignancy in this case, it's much lower than we saw for the unsatisfactory category. The risk of malignancy is up to 12%, but still in line with the other cytology classifications. The typical category should be used when the patient has a lymphadenopathy. We do see a monotonous population of small lymphocytes, or there is increased number of large cells, but there is no ancillary studies to make a diagnosis. And that's why the first part of my presentation, I focus so much on ancillary studies, because in the absence of ancillary studies, most of these lymphoid specimens would be classified as atypical. So, for instance, we have a older patient, I'm sorry, not older patient, a middle-aged patient with a small lymphocytes. Most of the cells are cleaved. Can we say that this is lymphoma? No, because we might be dealing with follicular hyperplasia, and the lesion might not be malignant, but we cannot rule out a low-grade follicular lymphoma. In our situation, it's where we see increased number of large cells. The differential diagnosis includes a reactive follicular hyperplasia again, partial involvement by large cell lymphoma, or even a higher grade follicular lymphoma. And in this case, we see a large atypical cell here. Differential diagnosis includes no not lymphoma, no lymphoproliferative disorders, or Hodgkin lymphoma, or even a T-cell lymphoma. Risk of malignancy in the typical diagnosis is higher, not as high as the suspicious. So it ranges between 30% to about 70%. The suspicious category should be used when the patient has a lymphadenopathy, either has a monotonous population of small lymphoid cells, there are atypical large cells. So different from the typical category, ancillary studies were performed, but they are non-conclusive. This is not either because the flow cytometry studies did not detect clonal B-cell population, or the immunohistochemical studies were very difficult to interpret. So in these situations, it's very important to obtain additional material. For instance, this case is a 63-year-old male with a retroperitoneal lymph node lymphadenopathy, and we know that retroperitoneal lymphadenopathy is highly associated with malignancies. Flow cytometry was collected. The immunohistochemical studies were not conclusive, and the differential diagnosis was the follicular lymphoma. Another case, it's a case of a 27-year-old patient with a mediastinal mass. We see these large lymphoid cells the IHC was suboptimal, and the differential diagnosis includes mononucleosis, Hodgkin, primary mediastinal large B-cell lymphoma, or even gray zone lymphomas, in which even with immunohistochemical studies would be very difficult to diagnose it. So the recommendation is to repeat core or excisional biopsy, and make sure that additional material is collected from proper ancillary studies. Sometimes, as I mentioned before, we might be dealing with a low-grade lymphoma, and the material that was collected was for immunohistochemical studies. In these situations of low-grade lymphomas, it's almost a requirement to get flow cytometry studies to get a proper classification and identify the clonal B-cell population. The risk of malignancy in the WHO classification is actually higher than the other classifications that we use in cytology. In the other classification, the suspicious category has, in average, a risk of malignancy between 80 to 86%. But in the WHO classification, you can see that the risk of malignancy is above 96%, or I'm sorry, above 88% in all situations. There are even 2 studies that all suspicious cases actually turn out to be malignant. The malignant category should be used when the patient has clinical presentation suggestive of a malignancy, such as a large mass or diffuse lymphadenopathy, has a monotonous population of small to medium sized cells, and we have confirmation with ancillary studies such as immunohistochemistry or flow cytometry. For instance, this case, we have a population of small lymphocytes with a morphology very suggestive of small lymphocytic lymphoma, and the findings are supported by the flow cytometry studies. This is a case of a follicular lymphoma where we have a perfect morphology, also supported by the flow cytometry studies. Or this patient with a neck mass where we see large cells, and of the cell block, these large cells were all CD20 positive. This is the case of plasmablastic lymphoma that we actually made the diagnosis on using cytology specimen with the cells where we identified this atypical population express CD138, EBV, and cytogenetics show the presence of a c-MYC translocation. The risk of malignancy in the WHO classification, the WHO system is very high, and you will see that actually it's not 100% in all the studies. Most of the studies had a false positive diagnosis. That's why it's so important to combine not only the morphological findings but also to have the proper ancillary studies. So when is histologic confirmation not required? It's not required when we're dealing with a benign reactive lymph node and we have a good correlation with the clinical findings and flow cytometry, when we're dealing with metastasis, or we're just evaluating for transformation, meaning that we know the patient has lymphoma and we're just looking for cell size. But we need to be very liberal and request a core biopsy when the ancillary studies are not very clear, they're not conclusive, or we need architecture, such as in cases of nodular lymphocyte predominant Hodgkin lymphoma, or in certain institutions, core or excisional biopsy is required for enrollment in certain protocols. And I highly suggest a close collaboration with the hematopathologist. Many cytopathologists do not have a training in hematopatology, And with all new classifications and molecular findings that are identified almost daily, it's very hard for the cytopathologist to keep up with the advances in hematopathology. And we have to make sure that we combine all the pieces of the puzzle in order to make a definite diagnosis. So in conclusion, I would say that adequate assessment is very important whenever possible. We have to realize that we cannot evaluate architecture in cytology. Ideally, we should use flow cytometry and immunohistochemical studies, but we have to understand the potential pitfalls. And in conclusion, we expect the WHO system for reporting cytology specimens to standardize the approach to lymphoid lesions, and hopefully will help us to guide clinical management. And with this, I would like to finish my presentation and open the forum for questions. Thank you.
Thank you, Dr. Lin, for that comprehensive overview of approaching neoplastic lymphoid processes and cytology specimens. That was really a really great foundation for us to sort of frame looking forward to the WHO recommendations for reporting. And I think that your presentation really nicely emphasized that, yes, we are very heavily reliant on ancillary testing, but you very clearly showed the limitations and the potential pitfalls. And so we really have to be aware of all of these, of all of the situations that you highlighted in your talk. So we do have a couple of questions, or at least one question from our audience. The question posed was, seeing that the malignant category needs ancillary studies, does that mean in resource-constrained settings, we can only end at suspicious for malignancy?
I don't think you need to be constrained to the suspicious category. I think if you don't have access to immunohistochemistry, but you have a clinical findings that support a malignancy, I think you can move to the positive for malignancy category. The problem is that you would have to distinguish, for instance, a large B-cell lymphoma from a carcinoma, and sometimes we find it difficult to make that distinction. Sometimes if you see many lymphoglandular bodies in the background in the Gibbs stain slide, it's highly suggestive of a large B-cell lymphoma. But I agree that if you don't have resources or access to immunohistochemistry or flow cytometry, it's okay to move to positive and say that you favor a large B-cell lymphoma in this situation. But at least in our practice, we would refrain from making a definite diagnosis saying, yeah, this is a large B-cell lymphoma. If the diagnosis based on morphology only, I would favor instead of making a definite diagnosis.
Yes, exactly. And I think when we're thinking about the differential diagnosis of non-hematolymphoid neoplasms, you pointed out in one of your slides, correct, that carcinomas that have a discohesive cell pattern, such as lobular breast cancer, signet ring cell carcinoma, but then I think you also emphasized seminoma even. So I think you were suggesting or emphasizing that knowing the targeted location is obviously key, correct? Any other, and then of course melanoma, and then it's obviously region dependent in terms of the most common presentations. There's another question that popped up. Okay, so this is a more of a, I think, a philosophical question. Given the importance of ancillary studies, can we get some support to our public hospitals to establish ancillary studies? And I'm not sure if Dr. Milner is still on the call, if he has some insight about that from his work.
Perhaps one thing that can be done, that it's centralizing the labs what that can perform ancillary studies. I think that's would be an alternative in resource constrained countries.
Dr. Lowe, do you have anything that you want to add, or any questions from your perspective?
None from me. Thank you so much, Dr. Lin, for this great presentation.
Thank you, Dr. Lowe.
Okay. I don't see any other questions. Let me see. I think there is something that popped up on the chat. We have a thanks from Okoe Innocent, and then another comment about a great presentation from Pam Michelot. So I think that is all that we have in the question and answer for now. And there was one other point. Oh, okay. So the other thing that I just sort of want to leave with for those institutions which are very fortunate to have flow cytometry and these other ancillary testing. It was great that you had the overview of the pattern, the different pattern types. But could you just summarize again? I mean, I can say it very briefly. For the small cell pattern, it appears that the flow cytometry is very useful versus the intermediate and large cell pattern, where the immunohistochemistry and other studies are favored over flow cytometry. Anything else that you want to add to that or clarify for those final points?
I think those are great, the key points.
Okay. Wonderful. Well, I think that we'll go ahead and conclude. Thanks again to our participants for joining us, and obviously many thanks to our speaker, Dr. Lin, for this wonderful presentation. And we will, as we've mentioned before, this session has been recorded and will be available at a later time. And we will look forward to seeing our participants for the next session. Thank you very much, everyone. Take care, and we'll see you next time.
Thank you very much. It was a pleasure. Okay.